going to be talking about my favorite topics, also the topics that I did my PhD on. And so I don't think this need to be too introduced, but I'm going to go into accounting for health opportunity costs in key decision in allocating resources in healthcare. So I'm going to talk a bit about the types of decisions that estimates of health opportunity costs can inform, and then I'm going to talk about how we go about estimating health opportunity costs. So it's a bit of a broad talk that covers quite a few different things, and I'm really happy to go into detail about any of the topics that I cover, particularly in the Q&A, and any questions for clarification, please feel free to ask those as I go through. Okay, so I'm going to give a bit of background, but I'm not going to spend too much time on this. I think this audience knows quite well what health opportunity costs are and why they're important. So I'll spend a bit more time talking about what these estimates can be used for. And I'll go into some detail, but broadly speaking, they can be used to inform key policy questions globally, looking across countries, decisions that are made by World Health Organization, global funders like the Bill and Melinda Gates Foundation, things like that. And then they can also be used to inform decision-making within countries. And I think this is what we're probably all most familiar with in cost effectiveness analysis, thinking about how we can use estimates of health opportunity costs to inform decisions around whether an intervention that the healthcare system might be interested in funding is cost effective or not. But we can also inform a broader range of questions that are relevant to a specific healthcare system. For example, thinking about designing a whole package of care, like a health benefits package, and a number of other things. So I'll get into some detail on each of these. And then, even though this section looks quite small on this slide, I will be talking quite a bit about how to estimate these. And then maybe a bit about future work at the end. Okay, so we all know what health opportunity costs are, but let's recap. So since resources are scarce relative to needs, the use of resources in one way means that they can't be used in another way. And so the opportunity cost of investing in a healthcare intervention is best measured by the health benefits that could have been achieved had the money been spent on the next best alternative intervention or healthcare program. And this is relevant whether we're talking about funding something from within a budget for healthcare, from within existing resources, which would mean that we would need to displace some healthcare that's already being funded. It's also relevant if we're talking about expanding the budget to include something new. So the key question that we need to ask if we're looking at funding something from within an existing budget for healthcare is, what are the health effects of the things that we would need to give up if we want to commit these resources to this healthcare intervention that we're interested in funding? If we're looking at additional resources, so funding something by expanding the budget for healthcare, the key question, did I do that maybe? Okay, the key question is, what are the health effects of the things that we could otherwise be funding that aren't currently being funded with the money required to fund the intervention that we're looking at funding? And so we know that estimates of health opportunity costs are relevant for informing decisions about whether or not we would want to fund a new healthcare intervention. They are often, well, they're not often actually, that's completely wrong. They could be used as a cost effectiveness threshold or a sort of approval norm, a decision-making benchmark by which we decide whether or not to approve something. And we know that actually health opportunity cost-based estimates aren't typically what is used as the approval norm. And we also know that using other estimates which have different conceptual underpinnings, for example, things based on the consumption value of health, these tend to be higher than estimates of health opportunity costs. And so we risk making decisions that actually reduce health outcomes overall if we use these types of estimates as a cost effectiveness threshold. But estimates of health opportunity cost are useful for more than just informing a cost effectiveness threshold. We can use these to calculate metrics of value that reflect the scale of the health benefits or the scale of the expected health losses associated with funding a specific healthcare intervention. So that allows us to go beyond these sort of categorical yes or no assessments of cost effectiveness. And we can measure these metrics of value in terms of their net health impact which is the net qualities gained, or we can think of that in terms of net DALYs averted. And we can also think of this in terms of its equivalent monetary value. So the financial value to the healthcare system, or the amount of additional healthcare resources that would be required to deliver the equivalent net qualities gained or net DALYs averted with other interventions. So like I said, these metrics of value reflect the scale of benefits or the scale of losses associated with a healthcare intervention. And that allows us to go and make informed decisions around a wider range of questions than just whether or not something is cost effective. So I think looking first at informing global recommendations. So the World Health Organization and the United Nations set targets for countries. Typically, most high-income countries are already meeting these targets. These tend to be targeted towards low and middle-income countries. Around, in terms of healthcare, they tend to be sort of things like reducing neonatal mortality by a certain amount, or increasing universal health coverage, and then they'll make recommendations around specific interventions that can be provided or should be provided, they say, in order to help meet and achieve these targets. And so these are made by WHO. They make blanket recommendations across all countries. But there's a question on whether these recommendations actually make sense for all countries. And by make sense, I mean, would they actually be expected to generate a net health benefit in every country in which it's recommended? Or is it possible that these recommendations would be expected to generate a net health benefit in some countries or most countries, but in some countries, actually, maybe this isn't the best use of resources, and resources could be better used in other ways, and funding these specific things would generate a net health loss. So then that leads to another question, which is, if it's not a good use of resources in these countries, is there a price reduction that would make it actually cost effective to fund these things? And so we can start to answer some of these questions, and we using these metrics of value. So we looked at a specific recommendation by WHO, which was part of the target to eliminate cervical cancer. And for that, the WHO recommended 90% coverage of human papillomavirus vaccination among girls by age 15. And so we looked at 4 different policy options, and we assessed these for Gavi-eligible countries. And Gavi is the Vaccine Alliance. So Gavi is an organization that negotiates with manufacturers on behalf of a group of countries to reduce the price to enable countries to buy these vaccines and provide them within their countries. They also help countries in terms of providing specific funding for delivering vaccines and things like that. So it's useful to look at Gavi-eligible countries because they tend to be the countries that wouldn't necessarily be able to afford to provide these vaccines if they had to pay market price. And they are actually paying a lower price. So we can have a look to see whether the prices that they would have to pay or are paying are meaning that this is a cost-effective use of resources in these countries or not. And we can also look at informing what prices would be appropriate for these countries to be paying. So we looked at 4 policy options, and there were 46 Gavi-eligible countries. So the first one was achieving the WHO recommendation at the average market per dose procurement price, which was $25 per dose. Then we looked at informing country-specific per dose procurement prices that would ensure that the vaccine generates a net health benefit in each country. And then we said, okay, it might not be reasonable for Gavi to negotiate prices for each individual country. So maybe they need to do it by country group. So we can think maybe by income group, for example, low income and lower middle income countries. And then what if we just take the Gavi negotiated prices given? Is this a cost-effective use of resources at that price? So we used data from the PRIME model, which was developed by colleagues at LSHTM. And these are the results. So looking at the first question, which is whether this would be a beneficial use of resources at the market per dose procurement price, if we plot the health opportunity costs in terms of DALYs averted against the HPV vaccine impact, also in terms of DALYs averted, we have then the zero net health impact line, which is where the vaccine is not generating a net health benefit, neither is it generating a net health loss. And so for the countries where it would generate a net health loss, these are all the countries that fall below that line, which have gray markers here. And the distance between the line and the marker is the scale of the net health loss that would be incurred in each country. And so what we can see is most countries, if they had to pay the sort of market average price, would see a net health loss if they were providing this intervention. But there would be a net health gain in some countries, and that would total 2 million. So across all countries, this would be quite a poor use of resources if we were taking sort of the net effectively. And then we're able to calculate the price reduction required for HPV vaccination to be cost effective in each country by calculating the net health loss and converting it into its monetary value. And so that would just bring each country's marker where it's generating a net health loss up to that zero net health impact line. And this is kind of a useful potential policy because it means that Gavi is, Gavi is sort of having to pay out the minimum or sort of pay the minimum difference in price between, if Gavi is the one paying for this, between the PERDOS market procurement price and the price required in order for it to be a cost-effective use of resources. But it's not necessarily a realistic policy objective. So we can also look at this by country groups. And that is, so if we were to apply the lowest price required for HPV vaccination to be cost-effective in any of the countries in the group to all of the countries in the group. But what this inevitably means is that on this figure, you would have some of those countries that had gray markers actually being up here. And so it's not sort of the most efficient use of resources, but it might be the sort of most potentially the best possible policy that could be done. And then we also finally looked at current Gavi funding. So we found that even though the Gavi model doesn't use this type of analysis to inform the price negotiations that they undertake, the price reduction that they achieved for the provision of HPV vaccination meant that there was a net health benefit for all of the Gavi eligible countries apart from 3, which is really quite good and says, I think, a lot about the good work that Gavi is doing. So this same type of analysis then can be used to inform priorities in developing new healthcare interventions by assessing the likely scale and distribution of the impact of potential new interventions on net population health at a particular price. So I have this just as one bullet in here because we don't have any published research on this, but this informs how the Bill and Melinda Gates Foundation prioritizes the development of new interventions as part of their integrated portfolio management. And it was sort of work that was undertaken in parallel with this work to come up with that strategy. Okay. So this work and so this HPV analysis and all sort of cost effectiveness analysis that we undertake typically discount health and costs to the present year to calculate net health effects. And it makes sense sort of why we do this. This is the way it's always been done. We know we've got recommended discount rates that are recommended by the World Health Organization and by the Gates reference case to undertake this kind of analysis. But this means that we are sort of balling up some implicit assumptions about growth in health opportunity cost of expenditure on health, which I'm going to call K in this part of the presentation, over time. So using the same discount rate for costs and benefits assumes that there's no real growth in K over time. And using differential discount rates for costs and benefits assumes something specific about the growth rate of K. So the discount rate for costs minus the discount rate for health would give us the real terms constant growth rate in K that's being assumed. But this isn't very realistic. We think actually K is quite likely to grow or decline over time. It's definitely not likely to be constant over time. It's going to change due to changes in the budget for healthcare, technical efficiency, the burden of disease within a country, the prices of funded healthcare, and not only is it going to be different over time within an individual country, but it's going to differ across countries as well. So there was a framework that was developed as part of the reference case guidelines for benefit cost analysis in global health and development, which was funded by the Bill and Melinda Gates Foundation, which recommends extensive reporting of the time streams of health benefits and costs over time. So instead of discounting health benefits down to their present value and discounting costs down to their present value, calculating an ICER, what it's recommending is to calculate net health benefit in each individual year in which there are costs and benefits occurring, and then to discount that net health benefit to the present value using the social time preference rate for health. But to implement this framework requires estimates of K, or opportunity costs, over time for all future years. So this is another piece of work that we undertook, which analyzed the cross-section between health opportunity costs and GDP per capita and other observable variables across countries and subgroups of countries. And using this relationship, we projected annual estimates of K in each year, in each country for 97 low and middle income countries for 2015 to 2040. Of course, this work was undertaken pre-COVID. So a major limitation of it is that a lot of the variables that went into this analysis will have changed since then. So there's some potential work. Right, so previously I talked about how we could use this to look across countries. And I guess the main take home of that is that health opportunity costs are going to differ across countries. They're going to differ over time across countries as well. And so what is cost effective in one country may not necessarily be cost effective in another country. And some of these recommendations that are made need to be thought very carefully about to reflect the local context. So we can also use estimates of health opportunity cost to inform decisions at the national level, not just about whether to include a new intervention within an existing package of care, but just we can think about designing a whole package of care from scratch as well. So this is one of the policy objectives of LMICs quite commonly, is to move towards universal health coverage. This is also one of the UN Sustainable Development Goals. And so what this means is providing essential quality healthcare to the whole population, ensuring that no one incurs financial hardship in obtaining it. So I spent some time in Malawi working with colleagues in the Ministry of Health to design a health benefits package there that was sort of grounded in the principles of economic evaluation, cost effectiveness analysis, and which took account of health opportunity costs in Malawi. So this work was published, but possibly more importantly, it informed the essential health package in Malawi, which fed into the health sector's strategic plan. And so one of the take-homes from this piece of work was that we could use our estimates of opportunity costs to inform net health impact, which we can use to prioritize between cost-effective interventions. And so when we're making decisions in high-income country contexts, we know, generally speaking, that the infrastructure exists, everything's already there, so these are marginal changes that we're talking about. But in an LMIC context, we have a lot more constraints. It's not just a smaller, more constrained budget, but there are also constraints around infrastructure, healthcare workforce, and loads of other things that kind of need to be taken into account. And so it's not just enough to know, okay, all of these things have ICERs below our estimate of health opportunity costs, and they would be cost effective here. But we also want to know, among these things that are cost effective here, which ones are the most important, which ones are the low-hanging fruit, and which ones should we be providing. So up until quite recently, I think this was generally determined by ranking ICERs and using a sort of league table approach. So I've just got an example here from the Disease Control Priorities Compendium, which takes evidence from across the world and gives us a list of the key interventions that are cost saving or have the lowest ICERs. And then this is a slide that shows some of the results from our work in Malawi. So The take home from this is that you can see a column with ICERs and then a column all the way on the right with net DALYs averted, and that's at full implementation. And we can see that they're ranked completely differently. And in fact, something that's cost saving might not even be ranked as the sort of most important thing according to the net DALYs averted, because the net DALYs averted is going to account for the sort of scale of the impact. And this becomes particularly important when things aren't being provided fully with the country, as is the case in a lot of low and middle income countries. So in Malawi, we did some analysis that looked at the existing things that were being provided within the health benefits package. And we found that on average, things were only being provided to about 50% of the population. So some things were provided fully, some things were only provided maybe to 10% of the population. It really depended on the intervention and what you needed to be able to provide it, the infrastructure that was required, if there was any sort of stigma around people going to seek healthcare for a specific intervention, for example. And what that meant was that fewer DALYs or less health was being gained than they set out in the health benefits package. And so there were different ways that we can think about addressing that. So one thing is we can think, okay, well, let's just expand the package and include more things with some of the money that we're not spending by not providing things fully. We can also think about spending some money to help scale up existing interventions, thinking about specific interventions. And we can also think about spending some money on healthcare system strengthening, on activities that we think are going to have an impact across all interventions and improving the uptake of all interventions. Okay, so if we want to think about implementation efforts by intervention, we can think about this in terms of what interventions, if we were to scale them up, would offer the most returns in terms of health. And so that column I showed on the right where we ranked things by net DALYs averted, that was at full implementation, but we can re-rank according to the current implementation and sort of the difference between the net DALYs averted at full implementation and at current implementation. That shows us where there's the potential for the most health gain across each of the individual interventions that we'd want to scale up. And we can also think about the maximum that we should be willing to spend to scale each of these up. And that is equal to the dollar value to the healthcare system, which is just the monetary value of that potential net health gain. And then we can also think about doing this at the healthcare system level, because it's likely that spending money on improving roads and ensuring that there's clean water at all hospitals, for example, is going to affect multiple healthcare interventions. And so for that, what we need to know is our sort of two bounds, basically. What's the sort of maximum health that we can gain by providing this package of care? And that would be if all interventions were provided at 100%, the budget was fully spent, and we didn't need to spend any money at all on scale-up activities to make sure that these were actually implemented. So this is sort of assuming that we have the infrastructure and the capacity and everything to completely provide these. That gives us our potential upper bound. Then we have the reality, where we have interventions at the level that they're currently being provided. So they're not provided at 100%, sorry. And also we are therefore not spending the same amount of money on everything. We're spending 50% providing an intervention that's sort of being rolled out at 50%, and this provides a lower bound to the health gain. So our absolute worst case scenario would be if we spent all of our remaining budget on system strengthening activities and they had no effect whatsoever. That's sort of as bad as it can get. If we spend that difference, that budget underspend, on some mix of healthcare system strengthening activities and interventions, then the costs from that will result in a point health benefits that lie somewhere between our upper and lower bounds. And we can then compare that to the dollar value to the healthcare system of scaling up all interventions. Yeah, okay, so I did include this slide, which is good. So this was our potential upper bound of health benefits, and B is our potential lower bound of health benefits. So if we spend some money, we know that on healthcare system strengthening, it's going to be somewhere between A and B. And then this allows us to answer another relevant policy question, which is whether we should just expand the budget for healthcare, or sorry, keep the budget the same, but expand the healthcare interventions that are being provided. And so if we don't do that, we know something about the expected health benefits from doing that. And we can plot that and we can see that actually that's not that much higher than B. And we think realistically, if we spend some money on healthcare system strengthening, it's going to result in some amount of health benefits from the benefits package that lies between A and C. And so in Malawi, this meant that there was a really strong case for spending money on healthcare system strengthening activities. Right, so I'll give one more example from the sort of benefits package stuff. So we also did some work to look at some empirical research that was able to inform scale-up activities. So we know that in order to prioritize between intervention-specific scale-up activities, we need to know something about current levels of implementation and how much it would cost to scale things up, and then sort of what's the maximum that we would be willing to spend on scale-up activities, so we can sort of rank and prioritize between these. That kind of data isn't typically available in real life. We often don't know the benefit that we would expect to see from spending some money to improve infrastructure or to train up healthcare workers to do a specific activity, especially in LMICs. But the WHO does have data on the costs and benefits of a number of different healthcare interventions at a range of levels of coverage. And so we were able to use this data to kind of illustrate how you would make these decisions. And so from that data, we could see that cost increased non-linearly with coverage for most interventions, and the benefits increased linearly with coverage for most interventions. So we looked at, I think it was 16 interventions for the Africa E region. And in order to be able to look at a wider range of potential coverage levels, we interpolated so that we had coverage at 0%, 50%, 55, 60, et cetera, all the way up to 100%. And then these are the results from that. So we had, sorry, also not to scare you, I'm not going to go through all of those. Yeah, so we looked at 3 different decision-making contexts. So the health maximizing context, which are the black bars. And then we have the context where we incorporate equity weights, which are the gray bars. And then we had a sort of all or nothing context, and those were the ones with stripes. And that all or nothing context reflects sort of the policy reality in a lot of situations where we say either we're going to include this or we're not going to include it. What we can see from that is the results of the optimization. So that is, given the budget, what intervention coverage levels we would have. So in the first scenario, where we allow for different coverage levels, we maximize health, given how costs and benefits would vary by coverage. So 7 interventions are provided at 100% coverage, while another 7 are provided at lower levels of coverage, and 2 are not provided at all. And then in the second scenario, we incorporated equity concerns. So for the purposes of illustration, we assumed that the patients who were the most difficult to reach were also the poorest, and we applied a weight of 4 to the benefits in the last decile of coverage, and a weight of 2 to the benefits in the penultimate decile of coverage. And in that scenario, there were fewer interventions provided, but those that are covered tended to be provided to the harder to reach portion of the population, in addition to the less expensive to reach parts of the population. And then the third scenario, again, just covers fewer interventions and provides less net health benefits than the first 2 scenarios. So that kind of information is not available at the national level for Malawi and for a number of, or for most countries really. So it sort of illustrates why it's important to capture data on how additionally expensive it would be to cover the more difficult to reach parts of the population, but also that it's sort of important to account for the equity concerns within that. And we also found within scenarios 1 and 2 that the net health benefit gains were quite similar, actually. So it's really a policy question of how much we care about those equity differences. So in the interest of time, I'm going to skip over the donor imposed constraints. But this is also, you can use the same type of analysis to look at donor imposed constraints and inform negotiations with donors to make sure that the government is on the same page as donors in terms of what should be provided. But I'm going to skip straight ahead to what I think is probably the more interesting section for a lot of you here, and that is estimating health opportunity costs. So we can see why health opportunity costs are really important for informing decisions internationally and at the national level. And the big question, how to estimate them. So I think that there's some work being undertaken to estimate that here. And so James is in the audience here. Myself and others have also worked on this topic, and we have written a paper with Laura Edney and John Carnan in Australia, who worked on the reference ICER for Australia, to try and bring together the sort of research that has been done on this topic to provide a sort of starting point for countries that are interested in undertaking this kind of estimation. Because this was something that we kind of got asked about quite a bit. So to start out, what you would ideally want to do is just look at what is going to be displaced when you fund a new healthcare intervention. But this is pretty much impossible to do in real life. So instead, what we need to do is to try and estimate the health effects of increasing or decreasing expenditure. And so from this review, what we found is that the methods that were used by different countries and different authors looking to do this differed. So there isn't really one obvious template that should be used. It really depends on the policy context of the question being asked and the kind of data that is available. Okay, so there is the perfect. So that would be identifying what will be displaced in its cost effectiveness by limiting expenditure to a new healthcare intervention. Again, like I said, that's not practical. So what we do instead is to get a causal estimate of the cost per unit of a generic measure of health, of expenditure at the margin of the healthcare system. That's quite a mouthful. But we used that phrase, that terminology, I suppose, to make sure that we captured everything that was being done and captured it accurately. So we need a generic measure of health, obviously, QALYs or DALYs, because this allows us to compare between different healthcare interventions, some of which might prevent premature mortality and others which might have effects on morbidity but not have any sort of survival or mortality effect. And ideally, we would have some kind of randomized control like exogenous variation in recent healthcare expenditures. And we would have measurements of time and cause of death along with lifetime health-related quality of life. So there are a couple of different levels of impossibility associated with undertaking this sort of perfect hypothetical study. So first, we'd be waiting a lifetime to follow up individuals to see the lifetime health effects of expenditure. And so it wouldn't be recent health expenditure that we would be looking at. That kind of a randomized control trial is really hard to envision. I think there would be some ethical questions around whether you could do something like that. Thirdly, health expenditure at the individual level does not always exist. And perhaps resource use and unit cost, these might be available, but even so, highly sensitive and difficult to obtain. And likewise, health data, including time and cause of death. And fourth, measures of health-related quality of life actually are not that common. So now that we know that the perfect is pretty much unachievable, what is good enough? So what we found in our review was that studies tended to split this out into two sections. So the first section looked at estimating a causal effect of expenditure on some kind of health outcome, mortality, was typically the most commonly used one. And we needed variations across geographical units or patient groups, and ideally over time, or both, in the relevant type of expenditure, which depends on the policy question, in measures of mortality and morbidity, where morbidity wasn't available, just looking at mortality. We needed variations in these same things in our controls for confounders, in particular thinking about healthcare need. And we also needed, ideally, to have some variables that affect mortality and morbidity only indirectly through their effect on expenditure. So some instrumental variables. Once we had a causal estimate, once these studies have estimated a causal estimate, they would then go on to part 2, which was modeling to extrapolate estimated effect of expenditure on mortality or the health outcome used to the impact on lifetime generic measures of health. And so this typically starts with, we have an estimate of expenditure on mortality. So we have a mortality effect that we can look at. Then how do we turn this into a survival effect? We need to use some assumptions to do that. Once we have a survival effect, how do we incorporate morbidity? So we need then to move on to a morbidity adjusted survival effect. And from there, we need to account for the direct effect of expenditure on morbidity, as well as the morbidity adjusted survival effect. And so there were different ways that papers did that. Okay, and then this is table 1. So the paper goes into quite a lot of detail. The purpose of this table is just to provide sort of a high-level overview. But the actual paper itself includes an appendix that gives a summary of what each of the papers did. So there were 8 countries that we looked at and 10 papers. So we have summaries of what each of these did, and then the paper itself goes through the sort of methods and the key methodological challenges that are faced and how these were addressed. So this sort of tries to summarize all of that. And this slide focuses on the estimation of the effect of healthcare expenditure on a measure of health, which forms the basis of part 1. So looking first at rows 2 and 3 regarding the econometric approach, we can see that studies tended either to use panel data employing unit fixed effects or cross-section with an instrumental variable approach. There was no study that uses individual level data, which we would ideally have, although that would necessitate completely different analytical methods to the ones that were used by the papers that we reviewed. Control variables are there to avoid bias due to confounding. And these are, in very broad terms, similar across the studies. In the context of cross-section, this was used to pick up unit or area level determinants of health that also determine healthcare expenditure. With the IV analysis, these are also serving to pick up confounding between the IVs and the determinants of health. So with the longitudinal or panel analysis, it is to pick up changes in area or group level determinants of health that also determine changes in healthcare expenditure. So importantly, the controls should not be influenced themselves by healthcare expenditure, as these would then represent bad controls, which would prevent the whole effect of expenditure on health from being estimated in the coefficient on expenditure. So most of the studies perform this analysis on mortality as the dependent variable, meaning that there are a number of steps that remain in part 2. But there were a couple of studies that attempted to bake in morbidity to the measures of health analyzed in part 1. So this represents part 2 effectively. So this tries to summarize part 2. And like I said, it's really hard typically to obtain good morbidity data with variation across geographical areas or the units that we need. So there was one study that attempted to estimate the effect of expenditure on morbidity, but most studies either incorporate morbidity into the part 1 dependent variable or applied the estimated effect in part 1 to some baseline measure of morbidity. So assuming that the effect on morbidity is proportional to the effect on mortality, as is done, typically is reasonable, and this has been supported also by elicitation exercises. by one of our colleagues at the Center for Health Economics, Marta Swaj. Different measures of morbidity were used across the different studies, and that depended on basically what was available within the country. So you can see EQ5D is used in some, SF60 is used in others, and then YLD, and that stands for Years of Life Disabled, which is a measure that WHO and the Global Burden of Disease out of Seattle, Washington use. There's a lot of debate around which of these morbidity estimates is the best, which one sort of captures things most appropriately. And there is some evidence to suggest that these can be used interchangeably. So in terms of results, so this figure shows the results that were available when we undertook this review. So there were 8 countries. So 2 are missing from this that I know of. There might be more actually now. But since this paper was published, Colombia published an estimate in 2022, and Indonesia also published an estimate in 2022. Yeah, so you can see there is quite a wide range, but generally speaking, these are not, well, very broadly speaking, these are definitely not as high as estimates that reflect their willingness to pay for healthcare or the consumption value of health. There's also another study that's not included in our review, which was done in the US, which James is an author on, which looks at dropping insurance coverage on mortality with a view to informing the opportunity cost of higher prices of drugs feeding through to higher insurance premiums. And that one's slightly different because it reflects quite a different style of healthcare system. Not included here. So in summary, there are 8 published studies that reflect country-level estimates of the marginal cost per unit of health. And some of the themes and comments around this are that the differences in the approaches used are driven primarily by differences in the purpose and the available data. So each study is specific to that particular country context. The main themes from part 1 are that the analysis has to control for confounding. Area level fixed effects and or instrumental variables, which at least should be used as a robustness check, are used to deal with potential residual confounding and reverse causality. Part 2, the main finding was that there was a lot of variation in how to incorporate the effect of spending on morbidity. But it needs to be done to be able to inform an estimate of health opportunity costs that can be used to make the kind of trade-offs that we need to do in making decisions around funding things across different disease areas and different types of healthcare interventions. Across the studies, it was really important that uncertainty was expressed and accounted for. And the assumptions all needed to be clearly stated and justified and tested where possible. And then sensitivity to alternative assumptions should be explored. This is also one of our takeaways from that review. So given the kind of data that's required to undertake this type of analysis, oh, I realize it's quite late. So just have like 3 or 4 more minutes left, sorry. So yeah, given the type of data that you need, not all countries have this data available. And so there are a lot of, there's basically room to estimate this as countries start to have this kind of data. Now that we know the kind of data that we need, countries can start to collect it and publish it, etc. But meanwhile, it would be useful to have some kind of an estimate for countries to be able to make decisions off the back of. And so there is a large literature that looks at the effect of health expenditure on health outcomes using international data. And so we wrote a paper that draws upon this literature, and we chose one specific instrumental variable approach, which was a paper by Bakari and others, which looked at the effect of expenditure on maternal mortality and under 5 mortality. And we extended their original analysis to include outcomes, mortality outcomes that could be translated into DALYs, and also included as outcome measures DALYs themselves. So we extended the data set to include adult male mortality and adult female mortality because that covers a broader swathe of the population. And it made it easier to be able to translate that into an effect on the whole population, and then also to look at then incorporating the morbidity components required. So we had results for 123 low and middle income countries using cross-country data. And this figure shows the results by GDP per capita. So the smaller dotted line at the top is 3 times GDP per capita, and the bottom one is 1 times GDP per capita. And what we can see from this is that a lot of these estimates fall below 1 times GDP per capita, with some falling kind of above that, but all are below 3 times GDP per capita. So you may be familiar with the formerly recommended WHO thresholds 1 to 3 times GDP per capita. And so this work sort of helped to show that those were too high, and that if you're going to be making decisions on the basis of 3 times GDP per capita, which is what WHO was saying was cost effective, you're actually going to be potentially doing more harm than good if you're looking at something that has an incremental cost effectiveness ratio that falls between the true estimate of health opportunity cost and 3 times GDP per capita. Also, we're saying that the dots here represent the sort of central estimate. So we look at 4 estimates, 4 different ways of estimating this. And so the lines, rather than being confidence intervals, are the range of estimates for each country. And then there's also possible implications for countries from sort of looking at the UK analysis and looking at how applying this across countries, what sorts of estimates you get. So the UK analysis found that the estimate of health opportunity cost was something like 0.5 or half of GDP per capita, a bit lower than that. And so if you extrapolate those findings using the income elasticity for health, then this is sort of what you would see across countries. Well, I'll go quickly over this. So we know that this is really an important thing in low and middle income countries. So if we look at a sort of global health production function, so they're diminishing returns to health at the top, but it's sort of in countries with the lowest expenditure on health where we're going to see sort of the biggest changes, the biggest differences. And this is a really important question, not only for high income countries where we have the data to do these kind of estimates, but also for low income countries where that data is more scarce. I think we all probably are familiar with this. So again, the WHO thresholds and even the NICE thresholds, these have other conceptual underpinnings. They might be norms, they might be based on the consumption value of health, which reflects the demand side sort of approach to thinking about this. These all tend to be higher than estimates of opportunity cost. So just in summary, using an estimate of health opportunity costs as a threshold ensures that decisions improve health outcomes overall. And estimates of health opportunity costs are also valuable for informing a range of policy questions relevant in LMICs as well as in high income